All right. Hi, everyone, and welcome to this episode of the Tiny Fit Diva podcast. I'm Kylene, Terhune, functional diagnostic nutrition practitioner, and this is Melody Harzler, clinical pharmacist. Yes. And I actually had her on last year on the podcast, and we talked about pregnancy and probiotics and babies, and it was a really great episode, so I'll make sure to put a link to that in the show notes if you want to go back and listen to that. But today we're going to talk about one of her specialties, which is diabetes and diabetes management, and she works with a lot of clients on this subject. So I'm really excited to talk about what all goes into it and how you work with these people. And sometimes I think there's a lot of information really with any medical condition that we just don't know about.
Sure.
So can we start with what is
Yes.
diabetes? Like, what's the difference between type 1, type 2?
Yes, exactly. So there's multiple types of diabetes. The major two types that you're most familiar with are type 1 and type 2. And so type 1 diabetes is actually an autoimmune destruction of the beta cells, which are the cells in the pancreas that secrete insulin. And so when patients are diagnosed with type 1, it's generally a pretty rapid progression, and the destruction of beta cells happens over a short period of time. They have really high blood sugars. Because they don't have any insulin in their system, they're actually at risk for what we call diabetic ketoacidosis, is where they get too much acid in their bloodstream. It can cause really, essentially, they could go into a coma. They could, have just really sick, like ICU type, needs at that point. And so fruity smelling breath is a common early sign of that. And so that's things to watch out for, especially in children that have fluctuating blood sugars if they already died. Obviously you wouldn't know until you're getting that diagnosis to watch out for those things. But so generally that used to be called juvenile diabetes. And so because mostly kids were diagnosed with it, or people, early adulthood or early childhood into teenage years. But now we've gotten rid of those juvenile and adult onset type designations because there's so many autoimmune diabetes cases happening in adulthood now, and type 2 is happening in children because of the obesity epidemic. So now
can't wait to talk about that.
So now we're calling it type 1. And then we also have a terminology called latent autoimmune diabetes of adulthood. And so that's when type 1 can happen in adults. Generally in adults, not always, but generally it's more of a slow onset. And so in that patient, they might present to the office. They might, because they're, 30 years old or 20 some years old, the doctor thinks they have type 2 diabetes. They get put on an oral medication that works for a little while. And then over the course of a year, then all of a sudden they need insulin because they don't have any insulin production anymore. And so a lot of times now we're, at least if they're coming to my office and I'm thinking, hey, you don't look like a type 2 patient. You don't have any risk factors for type 2. I'm going to screen them for those autoantibodies early on and figure out if it is an autoimmune process or it is a type 2 process. So
is that like a blood test?
Yes. So the one that's the biggest predictor of autoimmune is GAD antibodies. And so, and then there's also insulin autoantibodies as well, but the GAD is a little bit more specific. So we look at that, and then also can look at C-peptide levels. And C-peptide is present on someone's natural insulin, but it's not present on insulin someone would inject. So if we want to see how much insulin their body is making, we can look at a C-peptide level.
Okay.
And so that would be...
Because that's often not a problem with people that have diabetes. It's not
with type 2, right?
They're not producing enough insulin.
Right. So type 2, in contrast to that, patients with type 2, they don't have that issue. They have plenty of insulin, sometimes in normal levels, sometimes too much insulin, because their body's trying to compensate for the elevated blood sugar. So they'll have actually hyperinsulinemia, so they have too, high levels. And so that's, the C-peptide can be helpful. We have to be careful in taking a C-peptide at time of diagnosis when we have really high blood sugars, because it can actually be suppressed. So if you have glucose toxicity or too much glucose in the bloodstream, it suppresses the beta cells from working. And so you might get a C-peptide level that looks low, but then when the blood sugars normalize and you've treated the patient and gotten them back down to normal, then the C-peptide actually improves and looks normal. And so they're actually not a type 1 like you might have thought looking at the initial class. So it takes a little bit, generally the blood sugar has to be under 200, around 180 or less to do a C-peptide level to, have a normal level. And so with type 2, it's way more complex. So, I mean, obviously type 1 is complex too, because we just don't know enough, but I think because we don't know enough, it makes it a little bit more simplified. Like you don't know like triggers. I mean, obviously family history has to go into type 1 and the autoimmune piece. Environmental exposures, viruses sometimes trigger autoimmune things in children. But a lot of times there is a significant family history element of the type 1 diabetes or autoimmune things. So we're still not, no one really knows the exact answer other than that we know it's an autoimmune process. And then with type 2 patients, type 2 is even more complex. At least I think so. But we used to think that it was just insulin resistance and decreased beta cell function. So decreased insulin and resistance to the insulin. But now there's like 8 to 11 different mechanisms, depending on what articles you're reading, as far as like what's going on. And so the first terminology they used, an endocrinologist named Ralph DeFranzo, who's a very well-known person in the research world, coined it the ominous octet. And then now there's another, I think it was by Schultz, a paper by Schultz et al., who coined the term the egregious 11. And so there's like these like 11 mechanisms that are potentially going on in patients with type 2 diabetes. And so not only are we talking beta cell dysfunction, we're talking alpha cells in the pancreas to create glucagon, which is the signal to the liver to produce extra sugar. So in the fasting state, we want the alpha cells to tell the liver that we need to put sugar into the bloodstream because we need the blood sugar to be, above 70, ideally, to have, energy to our brain cells and our,
we need it.
Yes, we need glucose to function.
And so
even if you're in the keto diet type thing, you're getting glucose from the liver into the bloodstream. Like your blood sugar is not, non-existent. So we need it for our cells to thrive. And so that process happens from protein breakdown and essentially storage of free fatty acids turning into blood sugar. And so that process can actually, in patients with type 2, they have an excess amount of glucagon signaling to the liver. So they have this increased hepatic gluconeogenesis. So even when their blood sugars, when they're like, well, I'm eating fine, I'm doing this and that, well, they have that increased signal going to the liver. The liver's continually in that hepatic gluconeogenesis process or producing glucose process. And so that's sort of sabotaging them, as part of the process. We also have, besides that, if we look around like the circle, if you Google, ominous octet, we probably link a picture to the show notes, but you can see the different things. But we have, besides the decreased insulin secretion, alpha cell effects, we have that increased hepatic gluconeogenesis. We also have decreased muscle uptake. So that's like that insulin resistance that we thought about. So I like to explain it sometimes like a lock and a key where, you have an old rusty barn door and you've got this key, like the insulin is going into the lock and it should open the door, blood sugar goes from the, bloodstream into the cell. And so, but the problem is with insulin resistance is that doesn't happen like fluidly. So we've got this more rusty barn door that, needs some WD-40 that's like barely opening. And then some sugar is getting to the cell because the person's alive. They're functioning, but they've got all this extra glucose still outside the cell. So just enough is getting in. But that's why people feel really fatigued when they have high blood sugars is that glucose is sitting on the outside. It's not going into their cells to give them the energy that they need. And so we have that piece of it. There's also some neurotransmitter dysfunction going on and like the satiety response or that feeling of fullness after someone is, eating. Insulin's involved in that, but there's also, lots of the norepinephrine and all the different hormones and the serotonin and all of those kinds of things that are dysregulated in patients with this metabolic syndrome. And then we also have a decrease in incretin effects. I don't know if you know what incretins are, but incretins are the hormones in our gut when we eat food, we get GLP-1 and we also get GIP secreted. So GLP-1 goes and tells the pancreas to make insulin after you eat food. And then GLP-1 also tells the brain that you're full. It also tells the pancreas to not send that signal to the liver to make extra sugar. And it also slows the gut transit time because we have food now, so we need to digest it and be in that rest and digest mode. And so they've actually found that people with type 2 diabetes have less GLP-1 and they also have a resistance to GLP-1. So just like the insulin resistance, there's some resistance to the effect of that hormone. Interesting, there's some data showing multiple type data in this area, but like patients with type 2 diabetes that are put on a GLP-1 agonist, which is one of our pharmacological interventions, they actually, instead of having there's like a curve essentially, like for your insulin should respond, like as your glucose goes up, we should get more insulin response from the body. But a patient with type 1, that's pretty, or type 2, excuse me, that's flattened. And so it's actually pretty low. But if we give someone a GLP-1 agonist, then their glucose insulin response, it looks the same as if a patient was healthy without diabetes.
Oh, wow.
So there's GLP-1 plays a huge role in that process. And so I think that's something that we've more recently in the drug industry, or the drug industry has figured out, like that this is such a big deal in type 2 patients, that we have been able to address it with some pharmacological therapy. But there's also interesting data related to the microbiome, which is where the egregious 11, he brings in some of the discussion in his paper about microbiome and its impacts. But we found that like bifidobacter classification of probiotics, there's actually some evidence that people with type 2 diabetes have lower amounts of that. And when you supplement with probiotics of that family, you can actually increase endogenous GLP-1 levels.
Interesting. So have they found that specifically to be supplementation or like eating those fermented foods, or
so it's specifically that strain? So if it was or not strain, I should say species. I don't remember which particular bifidobacter, what strain was included. But so yes, if it was in fermented food, it can be beneficial. It's hard to, in a clinical study, figure out how much is actually being taken in and what particular strain is being taken in fermented food. But yeah, so they did use probiotic supplementation in the studies, and that particular study,
people
I think,
argue all the time about the benefits of either one. Yeah, so I was just asking because proven benefits that taking the probiotic did help.
And patients, and these were patients in like a pre-diabetic state. And so I think a lot of these like functional interventions really need to be like early on, like addressing, the gut microbiome, which you do all the time in all of your conversations. And so, so that's an element of it. And then there's also the increased lipolysis in the adipose tissue. So we know obesity has been correlated with type 2 diabetes.
Adipose is fat.
Adipose is fat tissue. Yep. And so the increased breakdown of free fatty acids actually contributes to further insulin resistance. And so that's one of the other pieces of the puzzle here with diabetes. But obesity is not the only cause of type 2 diabetes, because we can look at like a curve of BMI and diabetes diagnosis, and it's pretty, bell-shaped curve. Like there's not like up like this. So people with high BMIs get diagnosed with diabetes, people with low BMIs get diagnosed with diabetes. So there's other players going on in the picture, but it is, somewhat, it is related. We know that
it's like a risk factor.
It's a risk factor, yes. But
not everyone we
have patients in our office that are, we have BMIs over 40 sometimes, and the patient's blood sugars look great. In my mind, I'm like, how do they not have diabetes? They must have amazing genes, because if that was me, I'd be like super diabetic at that point. And then the other thing that is interesting is we found out the kidney actually plays a role in glucose regulation. And so our bodies are designed to conserve energy. And so when someone's like in the fasting state, the body is reabsorbing glucose, and you should not have glucose in your urine unless you're taking a medication that we'll talk about in a minute. But when the body is exposed to so much glucose going through, so someone starts to get this hyperglycemia state, when there's extra glucose going through the urine, the receptors, their job is to reabsorb glucose. So what are they going to do? They're going to actually increase the number of receptors on those cells and increase the reabsorption of glucose. So it's sort of a maladaptive response, but that's what the body's design is to reabsorb glucose to conserve energy. So we actually use that as a drug target now, and we can block the reabsorption of glucose in the kidneys and allow that glucose to then be excreted into the urine, and lower the overall glucose load for the patient. So it's really the only drug class that actually gets rid of the excess glucose.
Interesting.
Which they talk, I don't know, the book I was telling Kylene before we got started that I've read to just sort of get what this doctor's perspective is Jason Fung's diabetes code. And he talks a lot about, in the beginning chapters, how no diabetes medications really get rid of glucose, but then he talks about putting a patient in a case report on that class of medication. So I think I was like, well, there's not no medications, because this class of medications does. But yeah, so most medications are just going to be helping your body store that energy that's taken in, which then contributes to weight gain and things like that. But there are a couple medication classes now that do cause weight loss, particularly, the one that we talked to, the GLP-1 class, and that it's called SGLT2 because that's the transporter that it's inhibiting in the kidney, but that's the other medication that helps get rid of the extra glucose in the urine. And interesting, there's actually people that have a genetic deficiency in that receptor, and so there's there's a
so you have an autoimmune part, you have the genetic
part. This is particular with the SGLT2, so that receptor in the kidney, there's some people that don't reabsorb glucose and they always have glucosuria or like glucose in their urine. And so there's sort of a natural case report for what would happen if we continue having patients block that receptor and but they don't have diabetes, the patients that are in that natural, like for some reason their family history. So it just gives us an example of what well, these people are fine urinating glucose and there's no, issues with that long term. So it's sort of a cool case, to look at. Like,
so their body just kind of makes it work.
Yeah. Just homeostasis. Yeah.
Interesting.
Yeah. But yeah. So that's the main things, the microbiome piece we talked about. And then, so there's lots of different pieces of the puzzle as far as what's going on in someone with type 2. And so how do we address it is the next question,
well,
right?
figuring out what's happening.
Yeah, what's happening. Yeah. So from a lab standpoint, we look at A1C, which is a 3-month measure, and essentially it's called a glycosylated hemoglobin. And so it's measuring how much glucose is sticking to red blood cells. Okay. So it goes back about 3 months because the life of a red blood cell is around 120 days, which is technically, more like 4 months. But the biggest effect of it is in that first 30 days, 50% of what the A1C is reflecting is like the last 30 days. And then we get the next 25% in the next 30 days. So really 75% of your A1C is reflecting about 60 days of, in the past. And so there's other labs like fructosamine is another lab that's sometimes used. That's more like 6 weeks of a measure, but it's just not as well standardized and not as well studied and things like that. And so occasionally we'll measure that in patients that have like a hemoglobin variant. So their hemoglobin is like sickle cell, or there's some like hemoglobin F and different types of variants, oftentimes seen in African American population. But if they have some kind of hemoglobin variant, then A1Cs might not match up because their hemoglobin size and shape is different. And then like pregnancy, we have increased red blood cell turnover. So A1C is not the best marker to use in pregnancy for measuring glucose, or conditions where someone might be on like shots to increase their red blood cell turnover, for like Epogen or something like that. And then other cases where we might not use, like they have recent blood loss or recent transfusion, then obviously measuring someone's A1C probably isn't the best option. So that gives us a long-term picture. The downsides to an A1C is that we don't get the rises and the falls in the daily what's going on picture. Because we could have someone, so a goal A1C is less than 6.5 to 7 for a patient that has diabetes. A normal A1C is anything less than 5.6, because 5.7 to 6.4 is considered prediabetes. So 5.6 to
so that's actually a little lower, I think, than a lot of people think. That if they're around 6, they're like, oh, I'm good. Right?
So yeah, 6 would be considered prediabetes. So that would be, or compared glucose tolerance.
Low.
So the normal level for someone without any impaired. And then the hard thing is, it's like if you're at a 5.6 versus a 5.7, like clinically you're probably in the same situation. Or if you're at a 6.4 versus a 6.5, yes, we're not going to call it diabetes in the chart, but you've got some issues with glucose metabolism and insulin resistance and things like that. And so where you actually like draw the line. I mean, there has to be a line drawn at some point for some things, but we shouldn't treat the patient any different if it's 6.4 or 6.5.
And that's where you use like, how are they feeling, what are their symptoms, that kind of thing.
And what the risk factors are. And so, but other lab tests, we do glucose. You can just measure someone's glucose. And so the normal range of glucose is anywhere from 70 to 110 is a good fasting. 70 to 100 is more appropriate for like a normal fasting. The 100 to 125 would be more in that impaired glucose tolerance, or prediabetes. And then anything over 126 would be considered diabetes. But with fasting levels, it's like a one point in time. And so we have to technically confirm that to have diabetes diagnosis. So we want to check it more than once. If anyone has, like, they present with a blood sugar over 200 and they're symptomatic, so symptoms of diabetes would be like thirsty, going to the bathroom all the time, really tired. Those kinds of things are high blood sugar symptoms. So because we get to the point where the kidneys can't reabsorb anymore, then glucose gets spilled into the urine, and then with glucose comes water, and that's why they're going to the bathroom all the time. And so if we have symptoms and their blood sugar is over 200, then that's like an automatic diagnosis. They don't have to repeat another glucose level. And the last test that many women are familiar with is called an oral glucose tolerance test. And that's where we give someone a load of glucose and we measure their glucose after. So typically that's about 75 grams of glucose. And then we measure 1 or 2 hours later what their blood sugars are. So that's like the one, 24 weeks of pregnancy, people get their glucose checked or to figure out if they're at risk for gestational diabetes or have gestational diabetes. That's where they would.
So that's a good question too. Why would someone that doesn't typically have diabetes struggle with it perhaps during pregnancy?
So that's a great question, especially considering like some of the women that I've known as friends and patients that are gestational. They're like the skinniest people. They're smaller than me. And I was like, how do you, have this? I think there's a lot of factors. One, like pregnancy and being in that pregnant state increases insulin resistance automatically. The hormones, like if someone's pregnant and they're already diabetic, we know we improve insulin sensitivity in the first trimester or the second trimester. We start to get more insulin resistant in the third trimester. We get even more insulin resistant. And so if someone is diabetic, we have to monitor them through the stages and adjust, insulin because with diabetes, generally we don't use a lot of the medications because we don't know the safety in pregnancy. And so it's mostly the insulin being used, sometimes metformin. But there's also some people that talk about if you have children close together, there's an increased risk. And a part of me wonders if that's from some nutrient depletion potential, like, things like selenium and inositol and B vitamins are all sort of involved in some of that process. And so if, someone is...
It's always so amazing to me how a deficiency in one nutrient
biotin can play a role.
Completely throw you off.
Biotin can play a role in glucose metabolism and everything as well. So I think there's probably some things we don't know about the risk factors, but obviously if they have PCOS, they're at increased risk because PCOS has insulin resistance associated with it. And so those patients would probably be more likely to develop gestational, and then obviously family history and things like that play a role.
Okay. So we have lots of reasons that you can get type 2. We have lots of tests that we can do for it. Here's the $1 million question.
All right.
Is type 2 diabetes reversible? If you had, and I know you have to work with people who may be not willing to do this, but if you had like the perfect client that's willing to do whatever you say, I'll change my lifestyle, I'll do anything you tell me to do, and maybe medication is necessary in the beginning, is it reversible sometimes based on lifestyle?
Yes, I would say yes. If the person is willing to jump in, full force, if they're willing to do things like intermittent fasting or keto or things like that, like they could definitely reverse. There's things called like fasting mimicking diets that can be helpful in reversing some of these things. And that's
where you're actually eating, but it mimics being in the fasting
state because it's not essentially it's not carbohydrates. Although I was looking at the
Prolon diet,
and there is a honey in like some of their bars or something, but it's still
somehow they did it.
I'm just like,
it's so low calorie
ingredient, but it must be like very small amount of honey or something.
I'm sure it is. I mean, the bars are so small anyway. And the calories are so low.
I signed up on the website to get more information about that to see if it was like potential opportunities.
I think I actually have the book for that if you want to borrow it. Yeah.
Okay.
I think it's called The Longevity Diet. I'll double check, but you can borrow it if I can find it.
I think it's interesting. That whole concept is interesting because you are eating, but you're dropping your calories like drastically compared to.
See, to me, I don't even know because I feel like while the first 24 hours of a fast would be the hardest. After that, your hunger signals go.
Right.
So I feel like if you're doing a fasting mimicking diet, it might almost be harder because you're still eating. Yeah.
Well, that's what my husband said too, because we were looking at the price of it. We're like, oh, maybe we should do this as a reset. And then I was like, oh, maybe we should just not eat. Like fasting is cheaper.
Or I consider doing like a bone broth diet because that's also been shown. It's very similar. It's like fasting mimicking, but it's so filling. Because it's got the protein and everything.
Yeah, so I think if people are willing to, diet is probably more impactful than exercise. Exercise is impactful, but I do have some people that do great exercise all the time, but their diet is still terrible and you can't out-exercise a bad diet. I'm sure plenty of people have said that in the past. I'm not the first one to say that, but, and then.
Well, let me stop real quick because I want to tell a story.
Yeah.
My husband had someone that he works with, and this is exactly what you're talking about. He bikes 20 plus miles at a time. He's active, all this kind of stuff. And I don't think, I don't know where his food was. I don't think it was super healthy at the time. He ended up in the hospital because his blood sugars were so high. Wow. They were like, if you weren't as physically healthy as you were, you probably would have died from how high they were. Yeah. And so they put him on, they diagnosed him with diabetes and put him on insulin, all this kind of stuff. I think it's maybe a year later, he's gone really low carb. I don't know if he's doing keto, but he's completely changed his nutrition. Yeah. And last time he went to the doctor's like, I don't understand. You don't even, there's nothing that says that you have diabetes anymore. So he's not on any medication. Yeah, that's awesome. I have a similar patient story with a younger guy that was diagnosed with diabetes, and he used, it's called the Freestyle Libre, but it's a little sensor. I actually have a picture on my Instagram feed at farmtotable.life. Back a few months ago, I wore one for 10 days just to see what it was like. I taught my students I think I might have seen that. Yeah. I totally want to do that.
It's just you scan it. It's called an intermittent continuous glucose monitor, but you scan it and then it reads 8 hours back, and so you can see the whole day of what's going on. So
is it a prick in your skin that just stays there? Okay.
Yep. It lasts for 14 days, the newest one. And so that's really helpful for monitoring. Like we were talking about the different levels where A1C doesn't tell you anything about how much they're fluctuating, whereas continuous glucose monitoring, there's that one. There's one called Dexcom. There's actually a new one they insert every, it's called InterSense, but I can't think of how long it's inserted, but you insert it. I think it's 6 weeks, maybe it's 12 weeks, but they're trying to get longer and longer.
Anyone can get, or
so Freestyle Libre, you'd probably want a prescription for it if you have diabetes, because then it can get covered for your insurance. But as far as I know, you could just go buy one OTC
so someone
if you
just kind of want to monitor and maybe see
just for 10 days and see what happens. And
so
then,
what are these foods? What meals are impacting
that's
their blood sugar?
About the continuous glucose monitor is that you can do that and you don't have to prick your fingers all day to be able to do that. So you can scan and see okay, well, it's this before I eat, it's this after I eat, an hour later, 2 hours later. And it takes a while for things you're going to go up and come down. That's just the natural process. But if you don't have diabetes, you're not going to go up super high.
Well, if you eat pizza one day and you're like, whoa, that went up way higher than my other meals. That's a good sign, maybe.
It can help people make that decisions. Because there's actually studies that show that just adding continuous glucose monitoring to someone lowers their blood sugar alone without making any therapy modifications if they're a motivated patient. So
just because they can physically see that result.
Yeah. So my patient, he essentially went super low carb, keto type diet, and he's off medications and lost 30 or 40 pounds.
So would you recommend people then probably start low carb, not necessarily keto, or would that depend on the range that they're at, how severe it is?
Yeah.
If you go straight to keto, because I don't know if that would work for everyone.
The keto is not super well sustained for a lot of people. And so I think that is sort of a determining factor on the patient and what they feel like their abilities are. I think the couple challenges with keto is that you need fiber supplementation with keto, because otherwise the microbiome is going to change pretty quickly. We need good prebiotic fibers to grow our good bacteria, especially in patients with metabolic syndrome. And so definitely considering a fiber mend by Thorne or something with freshly hydrolyzed sorghum as an option would be good if they're going on keto. And then as far as low carb versus keto, the other thing with keto to think about is thyroid. So some people get concerned because there are people that end up having low thyroid after keto. And the insulin response is involved in thyroid hormone conversion. And so that's part of the reason why that can take place. My other theory is that they're eating a lot of protein, and then if they have a leaky gut or something that contributed to this metabolic syndrome or inflammation, that maybe then they're starting to develop food intolerances that can trigger some autoimmune type things. And so I get nervous with eating too much protein all the time. And granted, keto is more focused on high fat and not as much protein, but I know people that are seemingly keto that are probably doing more of a 50-50 protein fat, and protein eventually turns into sugar. So it's not quite ketosis like they envision it. So I think probably most data would suggest that the Mediterranean diet, if you're looking at the studies of what diet is best for people, the Mediterranean diet generally wins out, which is low glycemic. It's, not as much red meat proteins, although, you know, if you're picking grass-fed versus, you know, there might not be as much issue, but there's always a controversy on the red meat thing. And I don't think we have it completely figured out. I used to eat red meat, but I do like try to limit it to a couple times a week instead of like every night for dinner. And then also, you know, generally my approach in the office, if I'm treating my normal patient population that's not looking to do something super drastic. I mean, I will for certain people say, you know, I really think intermittent fasting is a good idea for you to consider. Or especially people that have trouble exercising and they need something that can really make a big impact on their blood sugars. But I don't recommend keto as often. I normally start with about 30 grams of carbs per meal or less. So that would be, if they're doing 3 meals a day, 90 grams of carbs a day. And if they have a snack, trying to stick with less than 15 grams of carbs, but really focusing on, you know, if you can just do a mostly protein fat snack instead of a carb snack.
And do you recommend trying to get those from like vegetables and things like that?
Some more carbs
so
and then
a lot less food
grains.
that way.
Try to skip out on the breads and the pastas. And then focusing on, you know, if you're going to eat a carb, because even when I was wearing, I don't have diabetes. I do have a family history of diabetes. So it's always nice to keep track of those things. But, when I was wearing that, I noticed if I eat a sweet potato, like nothing happens to my blood sugar. But if I eat, you know, something with sugar or something with a grain in it, the blood sugar would elevate more. Not that it's elevating to the level of someone with, you know, with metabolic
syndrome. That just makes sense because you're getting all the fiber and everything with, And
there's other interesting data that talks about that if you eat, there's like a study where they ate a chicken sandwich, a grilled chicken sandwich. So it had a bun and chicken and orange juice and a salad. So one group ate half of the meal, the whole meal, half the orange juice, half the sandwich, half the salad, and then 15 minutes ate the rest. One group ate the orange juice and the bread, and then 15 minutes later ate the chicken and the salad. And then the other group ate the chicken and the salad, and 15 minutes later ate the orange juice and the bread. So which group do you think had the lowest glucose exposure?
The ones that ate the sugar and bread last?
Yes. And so even just eating your protein on your plate first can decrease your like level that your glucose gets up to.
I'm so smart. I was really hoping I was right.
So good. So anyway, so that's something to consider, like for people that are like, okay, I still feel like I need a little bit of carbs, but maybe I can, you know, work it to where I do that. Timing of the food is important. So, or the people that are gonna, okay, I really want to sit down and have a piece of fruit because I love fruit. Well, that's great, but let's have some nuts before you eat the fruit or something with it that's gonna help reduce the peak of the blood sugar. So there's also, you know, people that would say the opposite of that because they would say, well, then you're exposing a person to glucose longer because it takes longer to digest proteins and fats, or that insulin resistance is created when you eat fat and carbs together. But I think for most people, it's not significant enough. I mean, if they're obvious, and milk is a good example. So people always say, should I drink milk or not? And it's, you know, always a question. And, you know, if you think about
never. In my humble opinion, there's no reason to drink milk.
Unless you're a child that needs more calories and tolerates it fine. But essentially milk is like designed for the body to gain weight, right? So infants are given milk to gain weight because it's like fat and sugar together. So lactose and, you know, the fat, natural fats. And so even though, you know, you think it's like a seemingly healthy with all the got milk campaigns and all these things like that, like having that fat with the carbs is like signaling the body to
well, then you're getting all the processed versions in the grocery store that don't have the full fat content, all this kind of stuff. So it's like, ugh.
Yeah. So my diabetics, sometimes I will tell them actually to have the full fat instead of the skim because it's not going to spike their blood sugar as much, but is it just causing them to gain more weight? Probably. I had a guy actually today. He was like, you know, whatever you told me last time really like set home with me. So he went home, he got rid of his breads and his pastas and his milk, and his A1C like dropped 2 points. So and we didn't really make any dietary changes.
He's a guy, so of course you'd have that.
I know, right?
No, that's really cool.
So women do struggle more to address with dietary changes, and the hormones and all the cortisol and all that kind of stuff can play a role. Not that men don't deal with cortisol issues, but it's definitely connected to the female hormones and all of the stress, you know, exposure and stuff too.
So one thing I want to clarify is that, you know, we're not telling people not to be on medication, especially in the beginning, because you need to, if you're going to do this, you have to be monitored through the process for sure. but find somebody that's willing to work with you on the lifestyle factors and the nutrition so that if you do want to get off of it, it's a possibility.
Yes. I'm not against drugs. I prescribe drugs through my consult agreements with my physicians like every day when I'm in practice, but it depends on what the patient wants. If I'm talking to a 70-year-old patient,
I'm going to eat my cake.
Right. He or she's going to eat, they feel like they've been, at a certain age. Yeah. I mean, we'll probably feel that too when we're 80 years old. Like, I need this, whatever. So I need their blood sugars to be controlled to prevent, so that we didn't talk really about the complications yet, but complications of diabetes include, vision impairments. It's the leading cause of blindness. It's also the leading cause of kidney dysfunction, and so kidney failure. And so I need them to have lower blood sugars to prevent those complications, because it's not diabetes that generally is going to kill someone. It's the, kidney dysfunction or the heart attack or stroke that they get after having blood sugars high for so long. And there's a lot more cardiovascular evidence, which we could talk about probably another hour sometime, but there's a lot of evidence about the highs and the lows and stimulating inflammation and things like that this glucose variability is contributing a lot to our cardiovascular.
Yeah, it's really interesting how many diseases, when people say, oh, you die from X, Y, Z, it's not always actually that. It's some side effect that just caused this cascade to happen in your body and it just stopped working.
So some people need drug therapy, and some people, and like I said earlier, like if we catch these things at the beginning, if we screen people appropriately, and if they're willing to make the drastic dietary changes, supplements along with side diet and exercise can do wonders. But then there's the opposite end of the spectrum where people are still eating fast food and still doing this and that, and they're not willing to make those changes. And that's the case where, like, as a provider, like, I need to say, okay, well, if you're not willing to do this, like, here's where we need to talk about medications, and here's, what I would recommend. And generally, our national guidelines, metformin is a common medication that we start with. And that's one reason it works really well. And it's also really inexpensive. We can get it for $4.
Do you remember when Starbucks came out that unicorn frappuccino?
That was like a crazy amount of sugar.
It was like 64 grams of sugar, I think, in like a grande or something like that, which is how many teaspoons, which is like excessive.
Yeah.
I will never forget, there was a girl on Facebook that has diabetes.
Yeah.
I think she even has like one of the pumps like on her body. Yeah. And she made this post about basically, screw it, because I have this pump and I'm going to have this unicorn frappuccino. And I'm like, you are literally going to kill yourself. Like, you can't, in my mind, especially when you're young, you can't do that. I mean, you're walking this tightrope of risk.
And type 1 patients do have an increase in those complications because they've had diabetes for so much longer. So the average age of diagnosis is probably around in the 40s and 50s for type 2. But for those people, so this, child that's diagnosed at age 2 now has an additional 40-year exposure to this disease compared to the majority of the type 2 population. And so, so they're more at risk for those complications. So they definitely, and it's hard in children because it changes as they grow. It changes, like, their needs for insulin change. Parent is not always the one with them. So they're, at school and they're being managed by a nurse and teacher and themselves. And, there's a lot of cool technology, though. The one CGM I was talking about, Dexcom, can allow for you to send a message to up to 5 people if they drop below a certain level. And actually, I believe the Medtronic program does this as well. So if they would go into a low episode, it would alert mom or dad, whoever's like loaded into the system, or school nurse, whoever. So we can act a lot faster because they have technology. But sometimes technology doesn't fix like the person part of it. And we're getting closer to this being like completely automated, to where like the insulin would bolus for you automatically if your blood sugar elevates, and they call it like the artificial pancreas, where we've got like glucagon and insulin going forward for the type 1 patient. So, but still, yes, if you have diabetes, like,
don't push it.
Because insulin itself creates insulin resistance. And so the more insulin you have to use, the more likely you're going to be able to develop insulin resistance. So even in that type 1
but typically once you're on insulin, it's this never ending cycle that your prescription keeps going up and up and up and up and up and up, because you need more and more, unless you do a lot of these other changes.
Things. Yes. Yeah. And type 1, maybe not necessarily, but type 2, more likely that would be the case. And
your body figures it out.
Unless you add in some of these other pharmacological agents that can reduce the need for insulin. So like GLP-1s and SGLT2s that we talked about before can drop their insulin needs for those type 2 patients.
So you had mentioned supplements. Can you talk about some health?
So we can briefly talk about that because I know we've already been talking
that's
for
all right.
45 minutes.
We'll wrap it up with supplements.
And I have to close on my house and buy my house again today. We're refinancing already because the interest rates have dropped. We just purchased a new house in December. And then the interest rate drops enough and we're switching from a 30-year to a 15-year and saving like $200,000 over the course of the loan. So it's like, okay, yes, we should do this. So,
for you.
So anyways, we're doing that again at 4 o'clock.
We're going to be neighbors actually.
Yes, this is so cool. I'm so excited. I'm watching her house like go up from like across the road sort of. Yes, so we're going to have lots more of these podcasts in the future, hopefully.
Over coffee, probably, on a really big island.
Yes, mine or hers. So as far as supplements go, so the first thing I like to think about is berberine. So berberine is beneficial in numerous ways, but it affects microbiome because it does have some antimicrobial things. So it's interesting because it can be antimicrobial, but also supports the growth of like the good bacteria. And it lowers blood sugar. It helps with cholesterol. It also has like a heart protective effect. And so that's one, you have to dose it higher than you do for like GI conditions. So GI, we might use like 200 milligrams 3 times a day or something like that. Whereas, for diabetes, metabolic syndrome, or cholesterol, it'd be more like 500, 2 to 3 times a day. So that's something to think about. And then, nutrient wise, selenium, biotin, chromium, vanadium. Vanadium is not necessarily an essential nutrient to the body, but it is like something in our food supply and can help. So I think Orthomolecular has a blend called diostinol or something like that. That name, we'll link it, or you'll link it. But that one has a blend of a lot of those nutrients. Zinc is actually really interesting nutrient. So there's studies of patients with prediabetes that were given zinc sulfate at 15 and 20 milligrams. There's a couple studies at 15, a couple at 20, or maybe it's 20 and 30. So we'll go with 20. But essentially they had a decreased progression to diabetes in the group that got zinc, and they had a lower zinc level at baseline compared to like general population. So zinc deficiency is very common in a lot of these gut disorders too.
Zinc and selenium are in a lot.
Thyroid disorder. Yes. Yeah. And so I think, that's a lot of the overlap piece in this nutritional deficiency piece. So that could be an intervention with prediabetes, is measuring zinc levels. Obviously we want to measure copper levels at the same time because we want to make sure there's a balance. We're not depleting copper by supplementing the zinc. Generally, we don't like to supplement with more than 20 milligrams of zinc a day just because of that risk for depleting the copper levels. But that can be an intervention that can be really impactful for someone's blood sugars. There's some data on cinnamon, which can be helpful for some people. Some people I haven't seen much of a benefit. But Sinulin is the sort of branded product that's available, that's in some of the other supplements, blends and stuff. But the trademarked one is called Sinulin, and they do have some data, and it is something that if you're needing a little bit of effect, that might be helpful. If your A1C 16, like that's not going to help. But get you where you need to be.
Do the combination, get the medication, and work on your lifestyle.
Sometimes we have to start medication and then wean off the medication. I think that's a challenge. A lot of people are diagnosed with diabetes. They think I'm going to be on this forever.
Right.
But if you do make those lifestyle changes, like you can definitely, like I started a lady recently on insulin because her A1C was in that 15 to 20 range. And it was a newly diagnosed patient, but she went home and made a ton of lifestyle modifications. So I had her on like basal bolus insulin because we weren't sure if it was autoimmune or type 2. And then turned out it was type 2. And so I was able to get her off the mealtime insulin. And so now she's just on, she's an elderly woman. So it's not, she may not come off the actual long-acting insulin just because of her ability to do some of the full-out dietary and lifestyle modifications. But for some people that are younger, like we could definitely work off that once you figure out like what the cause is and you reduce the glucose toxicity load. Because when you're in that glucose toxic state, all these supplements are not going to fix it. We got to reduce that and help the body to sort of recover before we get to that point.
So someone maybe started on medication, goes home, makes a lot of lifestyle nutrition changes.
Make sure you clue your provider. Because we
find
don't
a provider
that'll
work with you.
We don't want you to come back in a low blood sugar state because of that. So a lot of people, then call in and say, well, I'm having lows all the time and I'm feeling terrible.
That's a great point because sometimes when in some cases, when people make these lifestyle changes, their blood sugars can drop like overnight.
Right.
So some people have really strong reactions very quickly. So making sure you're monitoring it for sure.
Yes, making sure you're monitoring. And other nutrient I was looking here that I was going to talk about. Vitamin D does have some data for correlations to diabetes and increased risk, but not as much like treatment, like if we're like raising the vitamin. That's the interesting thing. We're like checking it. That's the most mainstream nutrient that's checked is the vitamin D level. If someone's going to check a vitamin level, or B12, I guess you might check a lot for anemia. But it seems like we have a lot of correlations to what low vitamin D can cause, but not a lot of data showing like increasing that vitamin D level then reverses that state. So, but it's still for prevention of other, things that low vitamin D can be associated with.
It's like
your immune system. The first time I checked it, it was terrible.
Mine was pretty low recently. We had to be supplementing, and it goes up really fast as well. As soon as you start supplementing, if you have a good physical response. So if somebody goes home, they make these lifestyle changes, let's say they're able to, however long, 3-6 months later, wean off, slowly get off their medication. Are the supplements something that would, since they're prone to this, something that would maybe be more long-term to help them manage?
Yeah, potentially. I guess it depends on like if you want to be able to cheat on your diet more or cheat on the low carb piece more, like you might need some more supplementation. But if you're going to go super low carb and do the intermittent fasting and you're not going to eat carbs, then maybe you probably don't need supplements. But I think a quality multivitamin that has the zinc and the chromium and all that kind of stuff is going to be important for someone, especially that had this metabolic, issue at
And honestly,
point.
I would say that for so
most
many people
just
anyway.
Because our soil is depleted of nutrients.
And so many of those, the vitamin D, the selenium, the zinc, magnesium a lot, vitamin C, so many people are deficient, even under RDA levels, which are fairly low to begin with. So it's like the recommendations you're making are almost good for the whole population.
I would say most people should be eating 90 to 120 grams of carbs in a day, like even if you don't have diabetes. Like it's crazy because there's a statement in the American Diabetes Association guidelines that said like for women to eat like 175 grams of carbs when they're pregnant with diabetes. And so there's not really any data to back that up. And so, but I had a patient recently that went and perinatal group told them that they should eat 175 grams of carbs by this dietitian that was just going based off that number. And it's just like, but her blood sugars are super well controlled with what she's doing right now. The baby's getting glucose because her blood sugar is in a normal range, just like any other woman that doesn't have diabetes. And so it's super frustrating sometimes is what patients are hearing from different providers and just going based off of some number that's on an article and not actually like the person sitting in front of you. And, you have to tailor that to your activity level as far as your carb intake. So if someone's super active, maybe needs more of those healthy carbohydrates if they're running marathons, but they probably don't
pair it with the fat and the
healthy protein. But someone that's like a busy, mom that's, working and taking care of kids and not having like me and not having time to exercise every day. Like I'd love to, but really I actually probably got like 3 to 4 days of a hard, good workout. And I try to walk, with the kids on other days when the weather's nice. But so that person, I don't need as much as a marathon runner. And so I think that's where people like, and the portion sizes in our restaurants and things like that.
So you said, what was the range again? That you'd recommend every day
for carbs? Generally like 30 grams per meal and like 15 for snacks. So that gets about to 105 if you're doing a snack in 3 meals.
For a day. So what do you know what like the average is actually that Americans would eat every day? I imagine it's
close
huge.
to 200 or 175. I mean, it depends if they're drinking pop, if they're eating like a lot of chips and fries and tortillas. And
it can go extremely fast. And here's the thing that I've noticed. If you are monitoring your macros and you're really, truly eating a whole foods diet, it's actually difficult to get it up that high. It really is. Even if you have a sweet potato, that's like not even that many carbohydrates. You think it is because you're like, oh, it's a carb.
Or something
you have 3 sweet potatoes in a day and you're not even going to hit that, And we think that's so carby and that people freak out when they're eating a whole food diet. They're like, oh, I still got to watch sweet potatoes or I got to watch my vegetables or I got to watch my fruit. And it's like, actually, when you're eating those foods, it's very difficult. If you're eating rice and pizza and ice cream, it's very easy. Like one meal.
The fruit is interesting because of the fructose has actually been linked to like be more detrimental than some of the other like sugars and starches.
Yeah.
And actually like fructose and like non-alcoholic fatty liver disease is a really high correlation. If you think about how much fructose people are taking in from like high fructose corn syrup.
Yes.
But even like in fruit, I find that tends to spike my patient's blood sugars like faster than some of the other like starchy vegetables. Which starchy vegetables have more fiber and things like that, and fruit does too. But.
So does that matter too if they're eating maybe like that kiwi or that apple with a meal versus if they're just snacking on that? Again, kind of that combo.
Yeah, I would just say if you're eating with a meal, it needs to count in that meal's carbohydrates.
Sure.
And obviously working with a dietitian or someone that's, nutritional practitioner can sort of help you figure out what your carb goals
I really want one of those monitors.
Yes,
I feel like that would answer so many questions for people.
Yeah, it's really cool. We can actually put them on in the office too in the professional sense. In the professional one, the patient's blinded to the levels throughout the week, at least with that brand. And so then they, don't see it and they come in and we download the report and look at their food diary and sort of put it together and show them, what's going on with their blood sugars level. But it's a game changer. Like in my last practice, I did not have that because it came out about the time I switched over from a federally qualified healthcare center to the private practice office I work in now. And so it's huge to be able to like, okay, this patient has an A1C of 7, but you're dropping to 50 overnight. And then going up to 300 after meal, after high carb meal, and then dropping back. And so, but their A1C looks completely normal. If a provider would test their A1C or normal, it would look like they're close to goal with their diabetes. And so, yeah, it's a huge game changer, especially for type 1s. They actually have pumps that integrate with CGM so they can actually it'll stop them from going low. So as they start to go low, it'll anticipate that they're going low and shut off the rate of insulin in the pump. And so it's huge. And eventually there's one pump system that does it on the low and the high end to try to keep them in range and adjust the basal rate. And then other systems are getting there quickly.
Technology.
So, the diabetes technology world is exploding. So it's really exciting for me.
It's super cool.
As I treat patients.
So long story short, find a practitioner that will work with you. And it's very valid, which I think it's just not talked about enough. It's very valid to make nutritional and lifestyle choices for diabetes because it can have a tremendous impact. So, Melody, where can people find you? Can you spell out your website?
Yes. I'm farm2table.life, L-I-F-E. So it's farm is P-H-A-R-M to table, T-A-B-L-E.life. I think I said this before last time I was on, but .com was like $5,000. And so .life was much more in the budget when I started out. Maybe
and
someday.
It's like lifestyle stuff anyway.
Yeah, it's lifestyle stuff. It's about my life. It's about, patients and interactions. So there's lots of cool things with the word life too. So I could have done .blog or something else, but I'm also on, Instagram at farmtable.life as well as Facebook. So check me out there. I have I don't know when this is going to get posted, but through the end of the month, I have like a contest to get some free stress away with Young Living's stress away.
That's a good one.
So yeah, we didn't even get to that. The stress impact on blood sugars and things. So maybe I'll have another episode on stress and all of that. But yeah, so that's a huge piece too to consider, and why people can't get their glucose under control is it could be cortisol.
Well, I don't want to stress you out.
Right.
With your signing.
Sign for my house again. Buy my house a second time.
So thank you so much for sharing your expertise. And I always learn so much from you.
Awesome. Thank you for having me.